Good morning. I'd like to follow up on some of the central themes that have been discussed already, primarily the need to expand Medicaid in the state of Iowa. The Iowa Hospital Association represents all 118 of Iowa's community hospitals, and our organization has identified this as the central theme, the linchpin to any health reform efforts in the state of Iowa. We've already provided to you a lengthy position paper, a formal document on this topic that's in your material. It outlines why we believe expanding Medicaid is not only good for hospitals, but is good for Iowa businesses, Iowa consumers, and the state of Iowa. I'm not going to go through all of those specific points. It's very detailed, but there are 5 broad areas that I'd like to touch on this morning in the time that I have available. First of all, as you've already heard, expanding Medicaid is essential to improving our population health. Up to as many as 150,000 Iowans would qualify for an expanded Medicaid program in Iowa. Numerous studies clearly indicate that people are healthier if they have access to health insurance. Failure to provide reasonable access to health insurance coverage is detrimental to population health, and it's inconsistent with our state's already stated goal to become the healthiest state in the country. And if you follow the news on that, we're actually moving backwards instead of forwards. Failure to expand Medicaid will continue that negative trend. Expanding Medicaid not only helps identify and treat chronic conditions at early stages, but it also provides a vehicle for moving people into health homes and other types of programs where their care can be managed more effectively. Second, I'd like to address the cost of expanding Medicaid. And critics of expanding Medicaid go to that issue and suggest that somehow it's not sustainable. Let's remember that the Affordable Care Act was passed under Congress's pay-as-you-go rules, so in fact it balances from a budgetary perspective. Approximately $158 billion of the ACA's cost is funded through Medicare payment reductions to hospitals. Those reductions are real, whether or not the state chooses to expand its Medicaid program. Hospitals agree to those payment reductions with the expectation that more people would have access to health care coverage, thereby lowering the cost of uncompensated care. Coupled with other scheduled cuts, those Medicare payment reductions to Iowa hospitals will total more than $2.3 billion over the next 10 years. Expanding Medicaid to uninsured Iowans is essential to help offset those Medicare cuts as intended by Congress during the creation of the ACA. Some critics have also suggested that the federal government will not fulfill its promise to pay for a 90% cost share of Medicaid once it moves to that level in the out years. The Iowa Hospital Association challenges that assertion. We have nearly 50 years of experience now with the Medicaid program, a state-federal cost-sharing program in this country. Not one of those 50 years has the federal government come forward and said, we're not going to pay our share of what we've promised to pay under Medicaid. So we believe that's a very thin argument. Charity care and bad debt levels at Iowa hospitals are at historic highs, and they're growing at about 10% a year. Currently, between charity care and bad debt, Iowa hospitals are providing nearly $1 billion of free care on an annual basis. Now, we all know that free care isn't really free. It's in the system. So expanding Medicaid to this population and covering some of this charity care burden would help offset costs to all of us who have private health insurance in the state. It also helps develop better primary care management, taking pressure off of hospital emergency rooms, which we all know is the most expensive entry point into the healthcare system. Expanding Medicaid provides more primary care opportunities to Iowans to address their needs before they reach that critical state. And finally, expanding Medicaid helps support our healthcare infrastructure. Iowa hospitals currently employ more than 70,000 people and are significant contributors to the Iowa economy, often one of the largest employers in their community. Iowa's healthcare sector has been one of the most resilient segments of the state's economy throughout our recession, and hospitals provide well-paying, high-tech jobs in all parts of the state. However, we all know that Iowa is already disadvantaged by unfair Medicare payment policies and have some of the lowest Medicare payments in the country. Failure to expand our Medicaid population walks away from important resources that could be injected into our state's healthcare economy and help us be able to compete for the nurses, physicians, and other healthcare professionals that we're going to be challenged with from other states which do expand their Medicaid populations, and there will be states to do that. Finally, I'd like to point out one final argument that's not in my prepared remarks this morning, but it's new as of this morning's newspaper in the Des Moines Register editorial talking about our state's mental health system. And it notes at the end of that editorial the connection between expanding Medicaid and what we can do in terms of continuing the evolution of working on our behavioral health system and how that can alleviate county's obligations and county property tax dollars in the mental health arena. Very important argument as we contemplate these very important questions. Thank you for your time.
Thank you, Greg. Thanks to the whole association for coming out so early in support of Medicaid expansion. Mr. Glass is up, followed by Sabra Rosener from the Iowa Health Systems.
I want to thank our hosts for allowing me to address the 2013 healthcare priorities of AMOS, which stands for a Mid-Iowa Organizing Strategy, and is an association of 28 churches in Des Moines and Ames, plus NAMI Greater Des Moines. My name is Bob Glass, and I'm a representative of the AMOS Mental Health and Substance Abuse Work Group. Understandably, our 2013 healthcare priorities are focused more on mental health. Our first priority is to ensure mental health redesign continues to progress with adequate funding. This is a great concern. For funding still needed in 2013, there is a need for level appropriations for 2014 and 15, and it will also need a long-term funding formula that is not another frozen levy. Second priority is Senate File 2315 called for providers and regions to be co-occurring capable, proficient in trauma-informed care, and use evidence-based treatments. So we urge the training of all providers to be co-occurring capable, to be able to deal with patients who have mental illness behind their substance abuse. There are so many of them like that. We urge also that a planful approach be taken to developing co-occurring treatment facilities. The ultimate goal should be the full integration of mental health and disability services with primary health care and substance abuse services. Thirdly, as others have urged, we also urge the expansion of Medicaid. In addition to many economic benefits, it will reduce the number of uninsured in the state, and it would also provide a better package for including mental health benefits to the estimated 68,000 Iowa Care recipients who will move to coverage under expanded Medicaid when Iowa coverage ends. When Iowa Care coverage ends July 1st of 2014. That Iowa Care does not cover mental health services is an unfortunate omission. Fourth, let us build a healthcare exchange in Iowa that includes the voices of the uninsured and the underinsured, so that their healthcare needs are what drives the exchange and is structured so that it can include their interests as well. Thank you for the opportunity to speak for our priorities. Thank you.
Thank you, Bob. Sabra Rosener from Iowa Health System, and followed by David Lyons. Thank you, Sabra, for allowing us to use your facility today.
Oh, you took my first line away. Hi, I'm Sabra Rosener, and I handle public policy for Iowa Health System. And we're honored to host this important policy discussion here at the Medical Education Research Center. So thank you for coming. The first point that I would like to go to, since we have to be efficient, I know, is about the Iowa Care Program. The Iowa Care Program is not an indigent care program. It's not working in the state of Iowa. Across the state, we are seeing patients suffering because they're not getting the care that they need. And not only are they not getting the care that they need when they do get care, it's not care that's coordinated. This is because they don't really have access to efficient and sufficient primary care. And so we would really like to see, and our number one legislative priority this year is to see the Iowa Care program restructured in a way that is meaningful for patients and that gives them the best care that they can get. So we will be working on that. We have been working on it and will continue to work on it to the last day of the legislative session to make sure that program is not renewed as it currently stands and that it's restructured to be a good indigent care program. Not only does it not give care to the patients that they need, that program, but it shifts the cost to providers across the state and turns those patients into charity care patients. Our Iowa Health System facilities, and this is not charges, this is actual care of cost, spent $27 million caring for Iowa Care patients. The problem with that is that the Iowa Care patient walks in, they think that they have insurance, and so they're trying to access primary care services, or they're trying to be a normal patient when really they're a charity care patient. And so the care that is accessible to them is a different type of care, usually being utilized through the emergency room. So in addition to that, when we look at the Medicaid program, we have been advocating and will really continue to advocate that the Medicaid program goes to an ACO model. We are certain that this will work. We have ACOs across the state of Iowa right now that are working for the Medicare program. I'll point specifically to Fort Dodge, Iowa. Utilization of patients is going down. Patient satisfaction is going up. Quality metrics are going up. How are we saving cost in Fort Dodge? Readmissions to the hospital are going down. ER visits are going down. Use of palliative care is going up. So we can do this in the Medicaid program as well. The state of Colorado has done this successfully. They've saved, even in less than a year, their Medicaid program has saved $3 million. We're also doing this at the Robert Young Center in the Quad Cities. We have an ACO for mental health patients, successful. The Medicaid ACO will allow collaboration between public health and private health entities. We would like to engage in this discussion further. We will be engaging in it throughout the legislative session with all of our legislators, and we would ask that both sides of the aisle can work on the Medicaid ACO policy, and that we my time is up. And that we, all of us, private entities and public entities together, can work to give the best care to the Medicaid patients and all the patients of Iowa that need care. Thank you.
Thank you very much. David Lyons, and then followed by Joe LeValley from Mercy. Welcome back, David.
Jack, thank you, Senator. Dave Lyons, Chairman and CEO of Co-Opportunity Health. I was asked to do two things today, and as you know, I've never spoken for just 3 minutes, but I'll try. First two things is to introduce you to the example of new infrastructure you'll have to work with in the state of Iowa as you implement reform. Co-Opportunity Health, for example, is a nonprofit, member-owned, member-governed health plan that will be able to serve individual small businesses and large businesses across the state of Iowa and Nebraska under the new reform system. We will be serving consumers and members through the exchange, and we can operate on a state exchange, a federal exchange, or a partnership exchange. We do intend to be able to collaborate with states on Medicare coverage and a seamless transfer from public to private programs, whether or not Medicaid is expanded or not, or something in between. And we will be actively outreaching and educating consumers and members throughout the state of Iowa and Nebraska on a statewide basis in the spring and summer, and we will be actively able to assist partners on the exchange as of October 1st. I was also asked to cover one other item. Why will some of these new structures work today when most of the efforts in the past 20 years have failed? Well, the unique combination of the tools Iowa has and the tools of the ACA make things a little different. For example, patient capital has killed a lot of the past efforts. Co-Opportunity Health has $112 million in financing already in place that will work through the next 15 years to implement reform in Iowa. Access to marketplaces. The exchanges change everything about how people can see the options they have available and match those options up with their needs. Adverse selection. In the past, you had to be very careful. You're the new player, you got the bad risks, so you went away. The 3 R's, the risk corridors, the risk adjusters, and the reinsurance, absolutely a game changer for new innovation in the marketplace. Organizational partners. You have now partners coming into Iowa doing things for the very first time in the country. Health partners from Minneapolis, Midland's Choice from Omaha, all focusing on the early cooperative activities in Iowa. So you've got some great partners who are willing to bring scale without us having to pay for it, which is a very important issue in the business plan. And provider innovation. We're working with affinity groups and providers, many of them in the room here, that already touch over 50% of the Iowa and Nebraska populations, and we haven't even started the education outreach efforts yet. So, bottom line, this is all doable.
Thank you, David. And you did make it in 3 minutes. You will be asked back again. Joe LeValley is up for Mercy Hospital, followed by Ted Bozen. Good morning, Joe.
Good morning. Thank you, senators and representatives. I'm not sure I want to say thank you. You didn't do me any favors making me follow someone as brilliant as Dave Lyons. But my name's, as Senator Hatch said, is Joe LeValley. I'm a lifelong Iowan and privileged to serve as Senior Vice President for Mercy Medical Center Des Moines. I'm grateful for the opportunity to speak on behalf of Mercy Health Network. Mercy Health Network is the state's largest system of member hospitals and other patient care facilities, providers. Currently, Mercy Health Network comprised of 40 of Iowa's hospitals, so that means I get 120 minutes, is that right? But seriously, 40 of Iowa's hospitals, 612 employed physicians in 142 clinics, and 13,000 employees, so a big part of Iowa's healthcare picture. We have several legislative priorities, and Sarah Adey, the Director of Advocacy for MHN, will be providing additional information to you about that, but I want to speak to 2 issues this morning that many people have spoken to. First is the Medicaid expansion. Mercy Health Network, with our legacy from the Sisters of Mercy, has always been an advocate for coverage and access for everyone. The ability to expand Medicaid created by the federal health reform law is a unique opportunity to improve the care for 150,000 Iowans, and we believe the state should take advantage of that opportunity. We understand there's concern about paying for it. When you think of expanding a health program, a lot of people immediately turn to that issue of cost, but as has been pointed out, hospitals in large part have already paid for that cost. As part of the negotiation on the original health reform law, hospitals agreed to billions of dollars in cuts to payments in exchange for the expanded Medicaid. So now, if the state doesn't follow through and do its part to expand Medicaid, Iowa's providers get the lose-lose proposition of big cuts in Medicare payments and no associated improvement in the Medicaid program. This is a potential economic crisis for Iowa's healthcare providers. We don't believe it's a sustainable healthcare system and puts Iowa's excellent system at risk. Most importantly, more importantly than all those economics, is the impact on people. We have 150,000 Iowans when Iowa Care sunsets who won't have any coverage at all, and we don't think that that's morally or ethically appropriate for a state like Iowa, where we take pride in taking care of each other. We also agree with some of the previous speakers that the healthcare delivery system has to change, and Mercy's proud to be a national leader in medical homes and changing the way care is delivered. I know Senator Hatch has spent some time with Dr. Swiskowski talking about some of the innovations we've implemented, and we have data to show that when you change the way care is delivered, you do improve the health of those patients and lower the cost of care, and we're happy and proud to share that information with anyone who's interested. I also have some remarks about the health insurance exchange. My time is up, so let me just mention that we certainly do support a state-based exchange.